Good morning, doctors, and how you doing? I wish this video find you well all, and the best of luck in your exams, whether was theory exams or clinical exams. I wish you the best. Today guideline is going to be the abstinence syndrome guideline from the neonatal guideline book. The reason that I choose this guideline today, it's coming up in the exam recently as a communication scenario as well. It could come as well in a history. So you have to have a good knowledge about this topic, and you can talk in this topic with confidence in the communications or in the management of if it was a history scenario. So let's start the abstinence syndrome, how you can recognize and assess a child or baby born with withdrawal symptoms. So it's basically neonatal withdrawal abstinence syndrome. These symptoms evident in babies born to opiate-dependent mothers and mothers on other drugs associated with withdrawal symptoms, generally milder with other drugs. So it depends whether it's mild symptoms or severe symptoms. So the time scale of withdrawal, the signs of withdrawal from opiates, it depends on the type of the illegal drug that mom has taken during pregnancy. So in cases of misuse of heroin, the withdrawal symptoms will happen or will occur in less than 24-hour time after birth. So you have to be aware of this time zone. So if it was heroin, you will find the withdrawal symptoms in the first day of life, basically. If the drug was methadone, the withdrawal symptoms will appear in a period of 3 to 4 days after birth. So it's a bit longer than the heroin, occasionally up to 2 weeks after birth. So that's the difference between the heroin and methadone. Multiple drug use can delay, confuse, and intensify withdrawal symptoms in the first weeks of life. Okay. So what are the minor signs in here? We have minor signs and we have major signs. The minor signs in here, the baby may express tremors when disturbed, tachypnea, which is fast breathing, more than 60 per minute, pyrexia, high temperature, sweating, yawning, sneezing, nasal stuffness, poor feeding, regurgitation, loose stool, sometimes diarrhea as well, sleeping less than 3 hours after feed, usual among breastfed babies. So these are the minor signs you may note on the newborn babies if their moms having a history of use of illegal drugs during the pregnancy. What's about the major signs in here? I highlighted the minor in green and the major in red just to remind myself, and as I am a visual person, so it's just to remind myself with that. Okay, the major signs, which is convulsions, profuse vomiting or diarrhea, inability to coordinate suckling, necessitating introduction of a tube feeding, baby inconsolable after 2 consecutive feeds. So these are the major signs. If there's seizures, if there's very severe or profuse vomiting and diarrhea, he can't coordinate his suckling, he can't coordinate his muscles to suck, to feed himself. He needs tube feeding, and if after 2 consecutive feeds he is unstable, he is uncomfortable. So these are the major signs. So what the aim for what I'm aiming as a doctor in here, to help this baby, I have to identify the withdrawal symptoms following birth. You have to be familiar with these signs, to give effective medical treatment where necessary, to promote bonding and facilitate good parenting skills. So baby need to bond with his mom after getting born immediately. Skin to skin contact, rooming, start immediately, breastfeed if mom happy to do that. It's not contraindication in here for breastfeeding. To support and keep baby comfortable during withdrawal period, to optimize feeding and growth. That's very important. He has to start breastfeeding if mom happy to do so. It's very, very important for his growth. To identify social issues and refer to appropriate agencies. You may need to involve the social and safeguarding here, the social service and the safeguarding service in here if needed. Okay, and here we have the antenatal issues, antenatal issues. So if you know beforehand that mom has she's using a illegal drug during pregnancy, so you have to check during the pregnancy or the antenatal period the maternal hepatitis B, hepatitis C, and HIV status, and decide on management plan for baby. So that's if the history is known. Mom has hepatitis B and C, HIV screen done, and so you can put a management plan ready for the baby who is going to be born in the next couple of hours. Okay, check maternal health care record for case conference recommendations and discuss care plan for discharge with safeguarding lead midwife and or drug liaison midwife. So if mom can't look after this baby after he is being born, you have to liaise with the drug liaison midwife and the safeguarding lead midwife regarding this, and to do what's the best for this baby. Okay, management of labor. During labor, as a pediatric doctor, what you gonna do? Make sure you know type and amount of drugs exposure. You have to know the type of medication that mom having during the pregnancy period and how much she's taking per day, how much the dose she's taking on daily basis of this illegal drug, the route of administration, which is orally, IV injection, whatever, when last dose was taken. It's very important. Neonatal team are not required to be present at delivery unless clinical situation dictates. So neonatal team not routinely be covering this event unless this, the clinical situations very dangerous and the baby at risk. So in this time, they may attend as a complete neonatal team. Okay, what's the immediate treatment in here after you gather all this information? So during delivery, so I highlighted this in red. Do not give naloxone. Do not give naloxone. In the past, they used it to give naloxone for moms who is taking methadone or any opiates, addicting any opiates. But according to the UK guideline, do not give naloxone. Can exacerbate withdrawal symptoms. So I highlighted in red. To myself, I remind you as well about that. Care of baby is as for any other baby, including encouragement of skin-to-skin contact and initiation of early breastfeeding if this is mother's choice. So breastfeeding in here, it's not contraindicated at all. Okay, after delivery, after the baby being born, you transfer to postnatal ward or transitional care and commence normal care. So you will care about this child or this baby as a normal baby. Breastfeeding, full care from A to Z, as a normal care. Admit to NNU only if there are clinical indications, so no need to admission for neonatal unit until there's indications or red flags. Keep babies who are not withdrawing, feeding well, and have no child protection issues with their mothers in postnatal ward or transitional care. So if the baby not showing any withdrawal symptoms that we have seen before, the minor and major signs, so no need to isolate the baby, no need to admit to NNU, no need to isolate from his mommy. No, he has to stay with his mommy as long as there are no any child protection issues as well before. So he will be in the postnatal ward with his mommy. Babies who are symptomatic enough to require pharmacological treatment usually require admission to an NU. So babies with major signs that we have seen before, if he is having convulsion, difficulty in feeding, he has profound vomiting and diarrhea, he is uncomfortable after 2 consecutive feed. He need a tube feeding. All these indications to admit to the NNU. Start case notes. You have to record everything, all notes with the date and time. Take a detailed history, including social history. Social history in here is very, very, very crucial. You have to focus on that to facilitate discharge planning. Maternal hepatitis B, C, and HIV status is very important. You have to ask about it in the history, or you take a permission from mom to do the screen for her. It's not my job, it's the gynecology team job, but you have to know about this. Ensure postnatal baby check and daily review by pediatrician. As symptoms of withdrawal can be delayed, keep baby in hospital 4 days or more. So just in case the baby did not show the withdrawal symptoms the first 24 hours and the first 48 hours, anyway you will keep the baby in a hospital 4 days or more, because as we have seen, the methadone withdrawal symptoms will be shown 3 to 4 days later, up to 2 weeks. So that's just to make to keep baby safe, and you spot the withdrawal symptoms if appeared late. We have subsequent management after you have stabilized the baby. What you have to do: aim for managing a baby at risk of neonatal drug withdrawal. What is the aim here? Maintain normal temperature, because some of them may got high temperature, sometimes low temperature. Reduce hyperactivity. He will be agitated and hyperactive. Reduce excessive crying. He will be irritable, uncomfortable, and crying a lot. Reduce motor instability as well. Ensure adequate weight gain and sleep pattern. Identify significant withdrawal requiring pharmacological treatment. Ensure baby reviewed daily by neonatal staff, so the neonatal team are responsible for the daily reviewing of this baby. For babies with minor signs, use non-pharmacological management. Swaddling, which is you roll the baby in a piece of a tissue, just to calm him down and reduce his activity and give him a peaceful feeling. That's all our grandma was doing in the past. We're still using this swaddling technique for some babies. Minor signs, that's they have excessive yawning, sweating, jitterness. That the swaddling will calm him down if he has minor signs of withdrawal. Start pharmacological treatment after other causes excluded. If there is recurrent vomiting, profuse watery diarrhea, poor feeding requiring 2 feeds, inconsolability after 2 consecutive feeds, and seizures. So only these indications need pharmacological treatment, which are the major signs. If the baby has minor signs, no need for any medical treatment. The assessment chart, there is assessment chart specific for abstinence syndrome, aims to reduce subjectivity associated with the scoring system. So I can score myself. I can't score this a baby having, for example, let's say, for example, 7 out of 10 score according to his situation. No, we have assessment chart that will guide us. According to this chart, we will put a management plan for him. When mother, I'll show you the assessment chart later. I have opened it up. It's ready. When mother has been using an opiate or opioid, for example, a morphine derivative is the most effective way to relieve symptoms. So if the mom has used opiates or opioids, in this situation, you will think of a morphine. Morphine will calm the baby down, will relieve the symptoms. When there has been multiple drug usage, like she is taking heroin with methadone, with amphetamine, whatever multiple drugs she is using, in this situation, you can use a phenobarbital, maybe more effective in this situation. So again, if mom taking opioid or opiate, morphine is the best. If she's taking multiple or a combination of drugs, illegal drugs, so in this situation, phenobarbital is the best choice. The opioids, okay. If authorized by experienced doctor, AMB, start morphine, 40 milligram per kg orally every 4 hours. In rare cases and after discussion with consultant, it may be necessary to increase dose by 10 microgram per kg increments. So again, in here they insisting, reminding you once more again with the dose of morphine. If mom addicted to opioids, you will start morphine every 4 hours, 40 milligram per kg orally every 4 hours. If baby feeding well and settling between feeds, consider doubling dose interval, and after 48 hour, reduce dose by 10 microgram per kg every 48 hour. If major signs continue, discuss with experienced doctor or ANP. Consider need for other medications, phenobarbital. So anyway, you will give the initially the morphine if mom addicted to opioids, and then you will take it from there. With the first dose, you already start morphine for him or for her. Baby feeding well and settle between the feeds, and he's doing well. The minor signs start to disappear. Consider doubling the dose. So in this situation, you will double the dose and double dose interval, and after 48 hours, reduce the dose by 10 microgram every 48 hours. So if he's sling and he's doing well, you will double dose interval, and after 48 hours, okay, and after 48 hours, after 2 days, you will reduce the dose by 10 microgram per kg every 48 hours. If he's still showing a major signs and there's no any improvement, you will discuss with experienced doctor. You may need, after discussion with the consultant or the experienced doctor or ANB, you may need to add the phenobarbital on top. The phenobarbital for treatment of seizures and for babies of mothers who are dependent on other drugs in addition to opiates and suffering serious withdrawal symptoms, you give phenobarbital 20 milligram per kg IV loading dose over 20 minutes, then maintenance 4 milligram per kg oral daily. Unless ongoing seizures, give a short 4 to 6 day course. Okay, for treatment of seizures, there is a seizures guidelines. We can read it later in another video. So that's the phenobarbital dose and how you can give it. We give loading dose first, and then we give the maintenance dose, which is 4 milligram per kg orally and daily. The chlorpromazine for babies of mothers who use benzodiazepines. Give chlorpromazine 1 milligram per kg orally, 8 hourly if showing signs of withdrawal. Remember, chlorpromazine can reduce seizure threshold. So this is a side effect of the chlorpromazine. He may trigger the seizures in here, but they give it to a mom addicted to benzodiazepines. So you give chlorpromazine for benzodiazepines withdrawal signs. Breastfeeding, unless other contraindications coexist or baby going for adoption, strongly recommend breastfeeding. So no contraindications, as we have mentioned before. Support mother in her choice of feeding method, whether she uses to breastfeed or bottle feed. You will support mom and teach her how she can help her baby to start feeding. So that's the last page of abstinence syndrome. Give mother all information she needs to make an informed choice about breastfeeding. Drugs of misuse do not, in general, pass into breast milk in sufficient quantities to have a major effect in newborn babies, and that's why breastfeeding is not contraindicated, as illegal drugs do not pass in breast milk in sufficient quantities. Breastfeeding will certainly support mother in and feeling she is positively comforting her baby. That will give her a positive feeling toward her baby, should he or she be harder to settle. Infections. Follow relevant guidelines for specific situations such as HIV, hepatitis B, or hepatitis C positive mothers. So in case mom has HIV status or hepatitis B or C, you have to be familiar with the hepatitis B and C guidelines as well. You can find it in the in the green book or the new blue book. HIV guideline as well. Give BCG immunization where indicated for baby. As I have mentioned before, there's an assessment chart for the babies showing withdrawal symptoms. The chart available for download from the West Midlands Delivery Network website. From this link, you can press on this link. And will take you to the website immediately. You can download the chart from over there, how you can score the baby according to timetable put on over there. Aim of treatment is to reduce distress and control potentially dangerous signs. Minor signs such as jitterness, sweating, yawning do not require any treatment, so don't attempt to treat these kind of minor signs. And baby will be with his mommy, roaming in, and breastfed as well. Has baby been inconsolable with standard comfort measures, cuddling, swaddling, or non-nutritive suckling since last feed, had profuse vomiting or loose stool, had an uncoordinated suck requiring tube feeding, or had seizures. If the baby showing all these major signs, so he probably need to be admitted to a NICU. Place a tick in yes or no box. Do not indicate any other signs in boxes. So the boxes that you will sign or highlight in the assessment chart looks like this box exactly. So you will record the time when you show a specific sign, like if he has profuse vomiting, the time exactly, if yes or no, it's indicated on the chart. Discharge and follow up babies who require the treatment. Ensure discharge planning involving social worker may not be needed if prescribed for pain relief and no other concerns. Health visitor, community neonatal team if treated at home after discharge, drug rehabilitation team for mother. If seizures occurred or treatment was required, arrange follow-up in named consultants clinic or as per local protocol. Babies who did not require treatment, if no signs of withdrawal discharge after 96 hours, arrange follow-up by GB and health visitor and advise refer to hospital if there are concerns, clarify need for any ongoing social services involvement. So for all babies, in brief, in summary, babies who require treatment, the discharge plan should include or involve the social worker. You may need involve social worker in here, the health visitor to check out the baby from time to time at home, the community neonatal team, if baby need to complete treatment after discharge at home, drug rehabilitation team as well, very crucial for mother. If seizures still occurring or still going, or treatment was required, so this baby need to have a follow-up appointment with a named consultant clinic or according to the local protocol of the local area where he live or where she live. Babies who did not require any treatment, they can be discharged after 96 hours, follow up with GB and health visitor, refer to hospital if there's any concerns or another withdrawal symptoms appearing, clarify need for any ongoing social service involvement. So that's the end of the guideline. Thank you for watching, and best of luck in your exams, whether theory or clinical exams. And I hope this you enjoy this video. Thank you and bye-bye.